Can everybody hear me? Good, because we have multiple mics. So we're here to talk about connecting older adults, and to get right into it, I first want to just thank our panelists, Kim, Megan, Tanya, Ryan, and I'm the moderator, Tim Lash from West Health. We were going to keep this pretty casual and discussion-oriented, and there's plenty of time for questions here. And I thought that what I would do was open up this session with a more macro perspective on at least why at West Health, where we're focused on aligning the delivery of healthcare with the needs of older adults and also lowering the aggregate cost of healthcare, why I think the time is right for greater connectivity, not just on the medical side, but broadly as we think about health outcomes. Because timing really does matter. You can have great ideas and real need, but unless the broader forces of the ecosystem and stakeholders align, it can be really difficult to get some momentum. So why am I encouraged here? A few reasons. One, everybody knows Gallup, the Gallup News Group. So we have a pretty large partnership with Gallup where we look at the sentiment of the populace around major issues as they relate to health, wellness, and specifically some of the medical outcomes. And it's very interesting. If you look back 4 or 5 years with the work that we've done with Gallup, and it's not just our work. If you look at sort of other survey work, this is consistent. There's this perception in America historically that we have very good health outcomes, right? And that's not just like if you get hit by a bus and end up, in the hospital, that we have great surgeons, but just like broadly, when you look at, sort of our health outcomes in the U.S., that we're doing quite well. And that's particularly true if you ask people about their own health outcomes, right? So, do you think you have access to great health care? Do you think you're getting, sort of, good outcomes? Historically, obviously there's segments that say like, no, I don't. But, overwhelmingly, people want to feel like they're accessing a system that's doing good. It's actually really uncomfortable to go to the doctor and feel like, well, it's not a very good doctor, but like, I'm going to go anyway, right? And, there's this dissonance that exists there, right? If you look at the work that we were doing right before the pandemic, there started to be a tick up of where people would report that, perhaps the quality of care, sort of in America, right, for some, right, is really quite poor, but it's not me, right? So if you look at these health disparities that exist, like no one wants to sort of accept the fact that they, right, might be in that group that's experiencing the disparity, feeling, overall, and this is a generalization, good about how I'm doing, right, but they lean into the reality that somewhere, right, there must be, segments that are not doing well, right? So, and we know that's the truth. People have been to New York before? Anybody? Okay, so the subway model. If you take the subway from Grand Central Station to the South Bronx, you lose about 6 months of life expectancy for every 1 minute that you're on the subway. It's crazy, right? If you could go the other way and get younger, right? I mean, like that's but actually you're losing life expectancy as happens. So you could say, okay, like well, you have to that's only New York, right? And again, this is like when you do focus groups on this, people like to think that it's somewhere else. It's not where I am. Well, if you go to just about every major city right across the country, whether it's Washington D.C., Chicago, Sacramento, St. Louis, within a 5 to 25 minute time drive, right, drive time, you can experience 8 to 10 years of difference in life expectancy, right? And so when we look at a broader level where, those of us that work in healthcare, right, and in medicine know that actually the data supports that the outcomes in the U.S., right, are not as good as other developed countries, right? On average, we do worse, right? And I set this up with where we were in the beginning with like what, sort of the American populace believes, because it always, it feels more comfortable to say it's someone else, right? That overall we're doing well, but these are disparities and it's pulling the average down, right? And that is why we see these broad disparities, from, one community to the other, but it's also why on average the US gets pulled down. And it turns out it's just a complete fallacy. So if you look at the health outcomes in the U.S. broadly, and not just, like you were in the hospital, but just life expectancy, mortality, all of those things, right? It is true that the U.S. is lower than just about every other OECD country, right? But it's also true that is the case at every single income level. So if you take the top 1% in the U.S. and you compare it to the top 1% in Scandinavia or the UK or in France, lower life expectancy, right? So, it's almost a linear relationship, right? So, like, you have this situation where, yes, we do have a subway model in the US where there are these disparities that have to be addressed, But we also have, if like Elon Musk built a subway, right, that connected major cities across the world, right, like you would lose life expectancy as you come to the US, right, and not just on average, but at every single level. So why do I bring this up? Well, we just completed another Gallup survey that we released about 6 months ago, and finally the data has flipped, where like people across the board are rating, on a report card A, B, C, D, E, or F, a D and F, that we have that the U.S. healthcare system is getting failing grades. And not just failing grades for other people, but failing grades on the outcomes for themselves. And so I take that as a major tailwind, right? That we've moved from a situation where there was this belief that, we're doing okay and somebody else might, need to do better, but like on average we're doing okay, to, well, wait a minute, we really need to act and we really need to change, right? And so as we look at the work that we're doing around transforming the delivery of care, it's impossible to imagine, right, that we're going to materially change the trajectory of our outcomes if we don't find a way to decentralize care, if we don't find a way to engage individuals and their families, right, around their health in a much broader way. And not just, through a sick care model where something happens and we're engaging, but how do we have a broader tether, right, into the communities so that we can manage the outcomes. And that's not going to happen unless we have broader connectivity. So I am absolutely excited that finally, the time has shifted, because people are starting to report it's not okay anymore, right? And if you're in a place where everything's okay, it's really hard to get change. If you're in a place where people are realizing it's not okay, it's a lot easier to get change, right? So that's number one. And then, broadly, numbers 2 and 3 of why there's reason to believe here. Healthcare costs have been, but continue to be a major focus, right? And there's now, if you just look at major companies like Walmart, CVS, and others, there's about $12 billion just over the past 18 months that have been poured in to, trying to transform some of, sort of the care. So we're getting private equity money, we're getting venture money. CMS is really struggling, whether that's a good thing or a bad thing, right? But, industry is starting to lean in, and, and that will drive innovation. I think it has to be, you need the bumpers, right, on, where that goes, but there's capital that's coming into this, on the private side, and states are obviously, we're here in California where there's major investments. So there's funding, right, and awareness that's happening then. And then, as tragic as COVID was and continues to be, for fortunately fewer, but continues to be, unfortunate for, individuals and families across the country, it really did shine a light, right, on the need for us to have greater leverage of our healthcare resources, and shine a light on the need for greater sort of mental and behavioral health, which, if there's one area where, through our survey work, that there is ubiquitous support, not just on the provider side, but sort of the individual line, it's that that we're going to have greater connectivity if we're going to solve that. So three tailwinds. People are finally, angry. I was going to choose another word, but they're angry, right? That we're not getting the outcomes that others, right, in other developed countries are getting, right? We're having capital and attention, from state and at the federal level on fixing this. And I think, there's a lot that we did not learn through COVID, but there are some things that I think we did learn, right? And I think that provides a great tailwind. So with that, right, I want to get into the panel. With all of this momentum, we're at this conference that talks about health, right? But as we know, health outcomes require much more than just the medical intervention of stuff. So as we think about connectivity, I think a lot of people think about a virtual visit with your doctor, right? Well, maybe I'll Skype in, right? Or we'll do something. But how should we even think about sort of defining connectivity in the broader context of health as we start, the journey, right, on, achieving more equity in this area? So we'll start there. Who wants to go first? I'll start with you, Ryan. Go ahead.
Jump right in? Good afternoon, everyone. I'm Ryan Kawamoto. I'm the Regional Program Manager for Older Adult Technology Services, where we run sites across the country called Senior Planet, where we empower older adults to use technology. So it's a real pleasure to be here this afternoon. And I think in defining health, I would actually say a couple thoughts. First, I'm the former executive director of an older adult community center based in San Jose, where we were much more of a social services model. We were doing case management, senior nutrition program, senior day services, so it would allow respite for caregivers. And I would say in this day and age, I'd actually like to broaden the definition of what it means to define health. I would like to include social services and comprehensive support, so that you're really thinking about the client, the patient, in a very comprehensive way. So I think that would be my first point. I think the second point then would be in how you define connectivity. And what we've been observing on the very front lines is there are 4 main components to connectivity. The first one would be having a device. The second one would be having broadband access. And the third would be digital literacy programming. And this is where OATS comes in to really provide that support. I should mention too that all of our programming is free. It's online at seniorplanet.org. We also have a national toll-free hotline where you can call, any older adult can call to provide, to receive support on any sort of technology issue. And the fourth component though is I would say we need ongoing digital literacy programming. And I separate that from the third component because it's one thing to take a class on how to use your iPad, but technology is moving at such a quick pace that sometimes that first class won't do it. And you're gonna need ongoing support. You're gonna need further classes. Overnight, Apple could change their operating system. Well, all of a sudden, all the materials that you've been using or the documents that you have to use your iPad become antiquated. So this is where it's really important for an organization like OATS, where we have a whole team providing all that overhead and all of that updated curriculum. That's where I feel like our comparative advantage is to come in to provide that support. And maybe I'll stop there.
Hi, everyone. Oh, can you hear me okay? Great. Tanya Bautista, I am the policy chief for the Department of Aging. And in my role, I've actually been able to support much of the initiatives that we've been able to establish through the Digital Divide programs that we currently are implementing. So what that has done for us in our department and for the Master Plan for Aging is really educate us on what resources are specifically needed, what partnerships are specifically needed, and we're also looking at how can we build in some creativity to where at a local level they're able to get the resources effectively to their community members, rural community members, just as much as urban and other settings. So from that perspective, we first started off with the chat program. And the chat program allowed us to take 4,000 iPad devices that we partnered with AT&T to obtain. And we looked at across the board through our area agencies on aging, how can we take these 4,000 iPads and make them meaningful for those who are experiencing social isolation due to the COVID-19 pandemic. That's how it started for us. That's where we landed, and there was a lot of urgency to get these devices out. But one thing we came to recognize early on is it's not just about handing out devices. It's not just, here's an iPad, good luck, have fun, hope you enjoy, this new technology. For older adults, disabled adults, and their caregivers, there's absolutely that need for digital literacy. There's absolutely that need to make sure they have sustainable connectivity as well as the device itself. So we took that pilot chat and we really went out of our way to identify these partners such as OATS and look at ways that we can make sure this is the whole package, that they don't have to go to multiple different sources to get each of these elements in a way that would just make it overly complicated to navigate and probably lead to unsuccessful outcomes for many of these individuals who need these resources. So that being said, we have built up these relationships. We've gotten to a place where we have over 2,000 iPads that have been distributed to community members who are now receiving digital literacy resources as well as the broadband access. And we are currently partnering with the California Department of Technology on the Broadband for All initiatives and the equity plans, so we can make sure that even if CDA can't sustain paying for this connectivity, that they do have long-term solutions that are meaningful from them. Now, how does this translate to us in my department from a telehealth standpoint? Obviously, I need to look at it through the lens of policy most of the time. I need to look at it through how can we successfully take these programs and implement them in a way that's measurable, and it gives us the outcomes that we can utilize to find long-term funding and other kind of program designs and implementation. So telehealth has become a big part of this narrative for us. And what I mean by that is it's not just looking at social isolation anymore. It's going past the pandemic. While that was a great learning experience for us and it helped us gain these resources to distribute to the communities, we look at it through the lens of telehealth in terms of we have a new environment in which all these folks have to interact. There is no going back. There's no, hitting the restart button and we're back to pre-pandemic experiences. This is something that we know older adults need to be able to utilize the technologies to connect with their providers. They need it for behavioral health resources. And of course, part of that behavioral health support is being able to connect with family, friends, making sure that their quality of life is sustained in a way that equals longevity for them. So we are well aware of the statistics around how social isolation in particular affects older adults in this manner. And we are taking that data and that research and the Gallup, survey results, and we're certainly applying it to how we can implement our policy successfully. And just to reiterate, the master plan for aging, digital divide is heavily baked into that when it comes to health and resources. So we are very fortunate to be at this policy window of opportunity in our state where we get to look at things through the master plan for aging that has been, supported by our governor, is something that we are committed to maintaining throughout all these departments and really ensuring that there is a collective approach that will be beneficial to the communities. So access to technology is another program we're currently implementing through the county welfare departments. And then we also have digital connections, which is another 16,000 devices that are currently being distributed throughout the state. And in all of these capacities, the three aspects that Ryan just described are baked in, and we're making sure that the funding's there and that creative opportunity at a local level can be sustained. Because the last thing I want to do is be a state department that thinks everything is, status quo, is the same for all. So I'm really excited to be here and support these efforts. And I will pass it off to.
Good afternoon. We got the after lunch time slot. So if anyone needs to, feel free to get up and go stand in the back. My name is Megan Rose. It is a real privilege to be here. I am the imposter on the panel. I am not a digital equity expert. My background is in housing and homelessness for older adults, and really trying to bridge the divide between housing and healthcare for older adults. And so it truly is a privilege to be here and just to talk a little bit about the way that we see it through the housing and homelessness lens. My organization is called Leading Age California. We are an association of over 700 nonprofit providers of senior housing care and services across the out-of-hospital aging continuum. So what that means in common language is we represent nonprofit affordable housing providers, assisted living, skilled nursing, PACE, home and community-based services, home health, hospice, you name it. And so there are a lot of digital challenges across all of those provider lines, but my focus is really on affordable housing and how we utilize affordable housing, which is chock full of low-income older adults across our state, as utilizing it in economies of scale fashion to be able to improve digital access. Because I think there's a real opportunity there, having all these older adults in these kind of somewhat congregate settings, to make a big change and to help improve these individuals' lives. Just brushing up for this panel, I learned some things that I had not known before. 42% of older adults in America don't have access to high-speed internet. If you are low income and an older adult, you're 10 times more likely to not have access to high-speed internet at home. And, those are kind of shocking. And as we talk about how to define telehealth, in housing we define health very broadly and telehealth very broadly. I think I completely agree with Ryan and Tanya, your definitions of how, broadly we kind of define telehealth, because we look at it as not just an opportunity for individuals living in affordable housing to connect with their primary care providers, their doctors, et cetera, but also individuals who've recently exited homelessness, and how do they connect with case management services. Older adults utilize a number of community-based services that might be kind of unique to older adults or people with disabilities. And then isolation, as Tanya said, is such a huge one. I didn't know that a senior facing chronic isolation, it has the health impact of smoking 15 cigarettes a day. Like, what? So clearly that should probably be included in the definition of telehealth if you're talking about reducing isolation and ensuring that these individuals who are often living alone are able to have that social interaction with family members, friends, caregivers, volunteers, et cetera. And so from now I'll turn it over to Kim.
Thank you. It's always hard to go last, so I can keep this brief and keep going. But it's really exciting to be here and talking about this because I want to encourage everyone here to expand their definition of telehealth and what it means to be connected. The digital divide, undercuts so much of our other work in housing, in food security, in isolation, in education, in workforce opportunities, that all of the effort we're putting in as a country to support people is really undermined when they're not online. And certainly when we look at how many older adults are disconnected, that's shocking. But after working with older adults for 20 years, there are some patterns we see. I think we have to address the digital equity work that's being done to identify older adults that need access to internet training and support. There are more pockets, as we heard in the broadband conversation earlier, than anyone sees when we're talking about, well, it's not me or it's not my immediate neighbor. It often is. There are over 1 million people in New York City, since we're talking about New York, who are not connected at all. That's a really big deal when it comes to accessing services. We have a really exciting opportunity right now in each state to come together to do digital equity planning with the Digital Equity Office. California is doing great work, and I encourage you to participate. This is a very democratic, community-oriented process to identify real needs as they exist in communities and allocate the right funding toward them. So if anyone has questions about that, please come to me, but it's going to take a lot of advocacy and a lot of sleeves up to help address the divide in general. And when you talk about magnitude, and since we're giving New York a little bit of a hard time today, and I live in New York, right when COVID started, the governor convened really smart people and, the former staffers from Google and a big foundation, and they called and they said, so we need to solve this problem with telehealth and older adults in New York State. We're going to send a bunch of volunteers to help every older adult in New York State to get them on their EHRs. And how much do you think that should cost? We have $100,000. And I said, that might get you a planning grant. But the idea that we can really underestimate how digitally disconnected so much of our population is in this country is one of the kind of most difficult things to face. So the more you can talk about it, the more you can advocate for it, the more you can check on your neighbors, your communities, the anchor institutions that are part of this solving this trouble, I think the better off we'll be. So,
great. Now the tricky part is to string this all together. So Kim, I'm going to go off of something that you just made on the point of what we can do, right? And if there's one thing that I could take away from this panel, right, it's that the definition of connectivity needs to move from like the medical side, right, and really think more broadly around where we get health outcomes from, right, and that really is, do you have somewhere to live, right? Can you even get basic connections with your families, et cetera. So how do you pay for it? And have we done enough to sort of really make the case that there's an ROI on it? And the reason I bring that up, part of my job, I run a small PACE program for all-inclusive care for the elderly in North County, San Diego. And during the pandemic, we put connectivity into almost every participant's home. And the idea going into it was like, well, telemedicine visits. Like, we'll get the doctor in there and the nurse in there. And we used it very little for that. Really, where it was leveraged was just checking in, telling a bedtime story, couple jokes. Did you take your medicine? And almost a pipe into the home to have a relationship. in our program, we can see the return on investment for that, right? But at an aggregate population level, my question is, right, have we done enough to date, right, to really support the ROI of the expanded definition, right, of engaging people, right, you know, sort of, you know, in their homes, where they're at, around things that are not an acute visit, right? And, you know, if so, then like, where's the data, right? And if not, like, what are some of the things that we need to do to really make the business case that, you know, that we should see, you know, greater investment to close this divide, not for the medical side, but, you know, for the broader, you know, sort of, you know, health outcomes that connectivity can achieve?
I'm happy to go first on that question. So the ROI is definitely something that the Department of Aging is invested in. We want to know more, certainly. We want to look at how effective are our programs, and in doing that, we get the opportunity to look at how this is improving the communities and giving us that ROI. We're kind of backing into it, right? So what we currently have in place is we are working with the University of Southern California, in which we're conducting surveys with over 2,000 participants throughout the state to confirm, did this have an impact on them? And what was that impact? So a lot of the questions are around social isolation, but they're around telehealth as well, in terms of what resources did they utilize, how effective did that improve their life? And we're really excited to have the rest of that data acquired by the end of this year and really look at how that information is going to benefit future programs and show that there is a need to invest in these opportunities. So that is one area in which we are associating that concept, and we're looking at the opportunities, because CDA also recognizes that there's a lot of great knowledge around that the digital divide exists. It's more of a chasm. We're looking at it through the lens of all these great resources that have been provided to us, but what are the solutions, right? Where are the solutions, and then what can give us that data in terms of, you know, the return on investments and that sort of thing. So that's where we're at. We're in the early stages of getting there, but it is our goal that as a department, we're not just throwing money at the issue and be like, here you go, figure it out, everybody. We are actively invested in looking at where can we acquire more data to prove what models are the successful models for older adults and how we can continue to invest in them.
Any other thoughts on that before we?
Yeah,
Kim?
I'm happy to go.
Okay.
So speaking, you know, from the housing space, it's been very difficult. I think the ROI is there. I think we're at this kind of interesting place in time where COVID helped us fast forward on proving the return on investment for digital connectedness. I think now it's getting everybody caught up, right? It's getting the government caught up, it's getting the ISPs caught up, it's getting the nonprofits caught up. And, you know, so in the housing space, we're making progress, but we're not quite there. So for instance, HUD has started to require that all new buildings or any substantial rehabs of existing buildings include community-wide high-speed internet access. However, they have not included any funding for this, right? So looking at the various funding sources, even here in California, it's easier to find funding for the initial development of the infrastructure in a building than it is for the ongoing costs. Affordable housing providers, they operate on shoestring budgets that are approved by the state, by the federal government, and there is no wiggle room, there's no excess left over to pay monthly subscription fees. So like in California, for example, there is some money in the public broadband account through the California Advanced Services Fund. However, you have to promise to offer free internet to all of the residents for a period of 5 years. And if HUD is not reimbursing for those costs, where does the money come from? And so these are, I mean, just a few of the struggles that we're kind of dealing with in the housing sector, where we have so many hundreds of thousands of older adults housed, and it's like very piecemeal. It's like, you know, puzzle piecing together various sources of funding. You know, when Ryan talks, I'm going to call it the three-legged stool, if that's okay, the kind of three components to digital equity. You know, it's getting the infrastructure built and getting it subsidized essentially for a period of time has really been the hardest part. And during COVID, we saw so many organizations that were offering these wonderful mobile devices to older adults, but without internet, how are they going to connect? And then finally, and I think what maybe is the most lagging is the third stool, which is how do we train the trainer, so to speak? How do we create that digital literacy and education and to really help sustain these programs and these models, as Tanya talked about?
I think I just want to add and call out kind of that elephant in the room of ageism. That's one of the reasons that older adults are disconnected, why we have not invested in digital literacy programs, digital inclusion programs. There's been a long-standing, at least in the last couple decades I've been working in this field, an assumption that, you know, the boomers will catch up. That people will just catch up, that technology is so intuitive now that anybody can use it, and that's just not the case. That's never been the case with new technologies throughout human history. So we need to find better ways to support older adults, to integrate technology into our other programs, and to really look at the consequences of ageism, of the assumptions that people can't learn. I've been part of training tens of thousands of older people of all ages and all abilities. People can learn when they're older. That's breaking news here. And we really need to accept that and fully accept that to be able to take advantage of the innovations that are there, that are beyond just using an iPad to talk to your doctor, but the sensors and the security options and the, you know, the high-tech side of all of this and the very low-tech side of being able to talk to friends and family. Those all have financial consequences and financial impact. And we're seeing so many studies coming out about those because we still need to, you know, determine that there's an ROI. But you can look at it two ways. There's the ROI for the healthcare system or for our communities, for our governments, if people aren't online, and how much that costs. If you look at you know, hospitals for readmission rates, if you look at transportation costs, if you look at you know, what it costs an individual who's not connected. And the programs that teach older people how to use telehealth report exceedingly that, you know, 92% of veterans that learned how to use their telehealth portal loved it, and they save between $41 and $50 a visit. Those are huge numbers for people living on a fixed income budget. People during COVID that could use SNAP benefits to order food through Amazon Prime. These are kind of hidden secrets that shouldn't be hidden. There are so many use cases that there's the personal tax if you're not connected. You know, if you need to order an airplane ticket, it costs $50 if you do that on the phone. You know, think of the ways individuals are punished for not being connected, and the ways that, you know, we are, you know, punished as a society by not being able to reach people. So there's those two ways to think about it.
And if I could add a few thoughts. So a couple years ago, we formed a Santa Clara County Digital Inclusion Working Group, which was multiple key stakeholders, and we started meeting with our county supervisors. And it was rather interesting because when we first started meeting, it was talking very vaguely about what digital inclusion is. And we started to recognize that if we actually started to talk about return on investment, we actually started to get more attention. So we actually pulled one study, and we found it's on Ortho Live, that telemedicine can save $1,500 to $7,000 per participant with fewer ER visits, less expensive specialist consults, fewer hospital admissions, and less hospital bed days. So potential cost savings of at least $3 million for 2,000 participants. When we started giving those citations, we started getting a lot more attention and a lot more traction. So I wanted to mention that. Second to that, though, I would also argue that in some ways, we'd like to change how we're measuring or the metrics that we're looking at. So for example, while there's a lot of emphasis on quantitative metrics, we'd actually prefer to focus on the qualitative. And this is where, again, I love working for Older Adult Technology Services because, and we are an affiliate of AARP, because if we define telehealth in a much more broad term, I was actually looking at our curriculum, you know, yesterday, thinking through like, okay, if someone asks, what does OATS do? What sessions do we offer related to telehealth? I was thinking, oh, well, we do a session on telemedicine. We do a session on how to find cheaper, you know, prices for prescription drugs online. But then as I started going through our curriculum, I was like, but wait a second. How do you access Zoom? That's just as important too. How do you do e-banking when there's a pandemic and there's a public health risk for you going to the bank, and sometimes going to the bank requires an appointment? I started to recognize if you start redefining telehealth in a much broader way, all of that turns into return on investment and providing comprehensive support for our older adult participants. On that note, older adult technology services, and you can find this report on oats.org, oats.org, and I recognize there's irony that I'm providing a lot of links, but this report is called Fly Like an Eagle. And our executive director actually did a few interviews with our participants, and one of our participants explained, and this happens to be in New York, that during the pandemic, she didn't have a device. And through our programming, she was connected, we provided a device. She said she felt like she was in a cage. And after getting support services, she now feels like this whole new world has opened up for her where now she can fly like an eagle. And ideally, if you can create that digital connection, I feel like you can open up those whole worlds, but we also have to start measuring it in terms of that whole new world and not just, oh, did you get a device? Oh, did you get internet access? And that's it. Or how many sessions did you attend? And then the final piece is to say that a while back, I met with the Stanford School of Medicine. And at that point, they were finding a lot of patients were having trouble logging in, but there were also a lot of patients that were struggling with anxiety and depression. And so in meeting with their professors, with their faculty, with their doctors, they actually asked if they could start prescribing our programming. I said, absolutely. If that can lead to better health outcomes, absolutely. And so this is where, when I look back to our curriculum, I wouldn't just include our sessions on even cloud storage or whatnot in more general terms, but I would say our discussion groups that are happening weekly, where people are building community online and being able to think thoughtfully online, I think that needs to be considered as well as we brought in this definition of telehealth.
Great. So Megan, the next one's coming at you, and then we'll broaden it. One theme that I've been hearing here, right, is that as we think about return on investment, that it's multifactorial, right? That it transcends multiple stakeholders, perhaps even within a government, multiple agencies. I spend a lot of time in DC, and it's very interesting. You go with CMS and talk about nutrition, they say, well, go talk to agriculture, because we don't do nutrition, agriculture does that. But when you think about connectivity, it's a similar thing here, right? On that you need multiple silos, which shouldn't be silos, but they are, right, to work together. And so, Megan, coming from the housing perspective, have you seen any bright spots of where groups have made sort of the argument that transcends housing to health to mental health to nutrition, because these things are all related? Are there bright spots there?
Yeah, I think so. I think that we've seen on both the housing and the healthcare sides a movement toward incorporating housing as a component of our long-term care system, right? And that's been our argument all along. It's like healthcare. It should start in independent living, right? We shouldn't be waiting for these health interventions until somebody is in care, right, in assisted living or has in-home care. And so what we've seen are some more collaborations and data sharing, like between HHS and HUD, for instance. HUD has recently hired someone, a position devoted to looking at health and housing programs. And so I think that all of this really folds into that, because as we've all talked about, you can't truly have healthcare without connectivity, because there are so many things that connectivity provides to all of us, especially older adults, to help them live independently, age in place, what is kind of a term that we like to use a lot, right? And I don't mean to throw that around lightly. I think we're all familiar with the term, but for those of you in the audience, I think particularly post-COVID, older adults, even more so than before, have a very strong desire to remain at home, in their own home, as long as possible. We know the data on moving into a skilled nursing facility, and unfortunately, when you move into a skilled nursing facility, your lifespan decreases statistically. Not to say that skilled nursing facilities aren't a very important component of our long-term care continuum, but allowing and providing an older adult the resources they need to age in place becomes very important. And so there are a lot of pilot programs, demonstrations out there that are seeking to help intertwine all of this. One model that we've been working on is called California Integrated Care at Home, and it relies heavily on telehealth and connectivity, because what it does is it embeds a community health worker, an RN, and a social worker on site in affordable senior housing. And that on-site team then is working with each of the older adults in that community and in the surrounding neighborhood to help make sure that they are connected into their primary care doctors, any specialists that they need to see. It's helping to coordinate their care. They're helping with care transitions when somebody is moving back from a skilled nursing facility back into independent living. There's somebody there that is communicating with the SNF discharge, that's communicating with, say, this person is ECM with their enhanced care management contractor, and helping to make sure that the person is supported. And you cannot do that without connectivity, right? And so I think we're starting to see this, like with the state launching the data exchange framework, and specifically targeting community-based organizations as organizations that have the option of joining the data exchange framework, because they see, I think, the benefit of having these community-based organizations sharing this data about the people that they serve with healthcare providers, right? It's all
Connected.
yeah.
I want to talk more broadly about ageism a little bit, for the whole panel. And I think appropriately, we've spent a lot of time talking about, connectivity in the broader context of just, societal engagement, right? And that I think is absolutely critical. But obviously connectivity and connectivity in context of health has a role in the more traditional medical sort of role there. There was a survey that came out, 7,800 physicians, varying specialties across the country. 63% of the physicians said or agreed with the statement that it's dangerous to engage older adults with telehealth. 63%, right? So that's a big number, right? So as we think about, sort of not just having a home connected or an individual connected, but having it actually being utilized, and I do think that's ageism coming out in those survey results, right? Is it sufficient just to engage with the user, the individual, right, and their families, or do we need to think about, more fundamental education at the provider level, for us to see the connectivity actually get used in a meaningful way?
I wanted to answer that because the disparities of how, telehealth, and when you're talking about providers and how critical they are, is the number one trusted source of information for older people is their physician. But there have been some very recent studies about disparities just in EHR access, and it's not just access, it's also when it's offered. So it's not completely broken down for age, but if you look across the board, so Black and Hispanic people were offered access to their EHR at much lower rates than white people, and they also accessed it at lower rates. This probably shouldn't surprise anyone in the room, but these all have real life consequences, and we see that age exacerbates most of the disparities that we can recognize elsewhere, and draw a logical conclusion that that's happening also with age. If you say that it's also an expensive problem, Becca Levy at Yale was just called out for her research that just ageism without digital anything, costs the medical field $63 billion a year in this country. So if we want to put a price tag on what ageism costs and does, it's a fascinating study. I encourage you to read it. It's well done. It's kind of like we need things we can digest. Numbers like that are so big are hard to digest, but it's real, and you can look at the different places where those consequences happen as part of this, ROI challenge that we've been talking about.
I want to get to questions in a minute, but any quick additions to that?
I think just to add, from, of course, the State Department's perspective on aging, ageism is a topic that we're heavily invested in, and where it comes from is we, in our lens, and from a policy perspective in particular, is identifying how we can build in case management and those wraparound services. So again, it's not just us handing out devices and hoping for the best, and that who they then in turn interact with won't implement their biases accordingly. We want that case management involved, especially through our area agencies on aging, as well as the county welfare departments, where we have partnered effectively to make sure that these individuals can receive the level of support that goes beyond just receiving a device and connectivity, but that they can utilize it in a way that they're getting the benefits that they deserve and need. So that is something that we are also trying to build, silo bust, build in those relationships, and then make sure that everyone who's involved understands the critical aspect of helping them through, obtaining the appropriate resources and programs that will benefit them, especially for aging in place. That's really big for us as well. So aging in place services, making sure that they can be in home as long as they can. We tap into in-home supportive services as a way to identify those who need digital inclusion efforts. And that's a lot of what we try to do from the ageism perspective. And I want to add just a little bit more to that is the cultural competencies of all of this. We identify that language barriers, cultural competencies, we want them to receive these, this level of service and this level of, I'm losing my words already, but in a way that they feel they are connected still to their community, and make sure that they really have something that brings them closer to who they are as an individual and what they want in terms of the rest of their life, really. So that's baked into how we are addressing ageism and aging in place.
That's great. Part of my job is to land this plane on time. So we have time for a few questions, and then we'll go to final thoughts. Questions?
Thank you, panelists. The message resonates to us at ARP. And Joe Garbanzos and I represent ARP California. The theme is complex, as you pointed out. But there's a piece to the digital divide that focus on the need for programmers who develop programs and algorithms that might not be user-friendly for the elderly. So I'd like you to offer some insights, maybe examples, where you're able to work with program people to develop programs and algorithms that are useful for the end users. Thank you.
Single login. But
Passwords, no. Actually, there's a big study that was done across a lot of age tech platforms and found that 71% of them used outdated, biased stereotypes about aging, assumptions that were not accurate. We have so much work to do, I think, still when it comes to making what is available truly accessible, especially for older adults, but with anybody who has any types of challenges with it. And I think since people learn technology from seeing utility in somebody they consider their peer, having more opportunities for that peer learning, for culturally sensitive learning, to understand that an older adult who's 75 and trying to use telemedicine is maybe not supposed to be in the same class at a library with an 18-year-old mother who just came with her child from Honduras. These are not the same skills. It's not the same type of learning. I think Ryan can attest that it's much easier to teach an older adult technology than to teach people to be effective teaching older adults technology. So I think we need a lot of time and investment in that to really create supportive environments that are ongoing, that can really address the needs that people have.
And I just want to give a shout out to the Lighthouse Project. I don't know if any of you are familiar with the Lighthouse Project. I cannot take any credit for the work that they've done. I'm just an ambassador. But they are really studying through the Lighthouse Project, which was with the Citrus project at UC Berkeley, and Eschaton, which is a local nonprofit provider here, and Front Porch, a California-based nonprofit care provider as well. They really looked at how to improve health outcomes through digital equity. And one of the things that they did is they realized that you can't just assume that all older adults have the same needs, right? You have one older adult who may have vision impairment and another who may have hearing impairment, or another that has challenges with dexterity. And so what they did is they created an empathy survey. And this is a survey that can be used in a number of different settings to really understand the people that you're trying to help and what their individual needs are, so that you can tailor the technology solutions to their needs. And they also looked at a number of different technology solutions and have kind of a report and feedback on what each provides and which worked better for different people with different impairments or disabilities. And so anyway, their playbook is forthcoming. I encourage you all to visit their website. So hopefully we'll see that in the next couple of months, but I think that's going to be a huge help to anybody that is working with older adults in this space.
I think we have time for one more question, and then we'll wrap this up.
Unfortunately, it's not necessarily a question, but a comment. In my world, what's so frustrating that I've come across is that on the federal level, access is actually getting a lot harder through Social Security and CMS. You know, 2 years ago to apply for Medicare was fairly straightforward. A neighbor, a friend could help. And now the levels you need an email address and a cell phone that you can actually have access to while you're actually applying that's unique to you, or they send you a code, and if you don't do it correctly, you're locked out for 10 business days before you can get back in, where they can mail you a code. You know, it went from, a crisis across the board because everyone was calling Social Security to apply over the phone, and they were calling back, and now they're making the waiting periods past the Medicare enrollment and being sort of snotty, because you can only apply 3 months prior, and if you're calling 2.5 months, oh, well, you know, you should have called 2 weeks ago, we can only get you in. And of course, having Medicare A and B in place is critical to enroll in prescription drug plans, which again, you need connectivity for. So yes, all of these are important, and I'm just passing on that unfortunately the federal government is actually making it a lot more difficult right now and not easier.
Great point. Thank you. So we're going to do 30-second final thoughts, and Kim will start with you, and I'll give you 30 seconds to think about it. So we started today with sort of some of the tailwinds that I identified, right? And I'll just offer one more tailwind that I think is going to be absolutely critical to this space. And what used to be called value-based care is now comprehensive whole-person care. And I think as we start to align payment with those specific outcomes, that a lot of the problems that we face today on all of these issues being interdigitated with one another, right, will start to resolve themselves, because it is about return on investment and for the individual, their families, but also the dollars need to make sense. And I think when we get better alignment there, outside of the fee-for-service model and into the more holistic model, that we'll see a very considerable acceleration in this space. Kim?
Thank you. I think I'll be short and just say that what we really need to do as a country and as individuals and as providers and communities is change our mindset from the challenge of the digital divide, from a personal issue, seen as a personal issue, to seen as a social problem that is going to take a lot of work to support. It is not the individual's problem. When they're not online, it is our problem as a country. And to help change that narrative, change that mindset, and really start with changing the narrative around aging.
And I would just really encourage everyone to participate in the state's digital equity planning. There are going to be a lot of opportunities for engagement coming up, and we really need to make sure that the voices of older Californians are heard in this process, so that they are included in the plans and we can start to really make some headway on this.
And just to touch on some of the things that were brought up, the Department of Aging is well aware of the income disparities as well as the access to these health programs. And in that perspective, we really designed these digital inclusion projects to be not income-based, not associated with what health, provider you're linked with. It's really meant to be tailored to, anyone who needs these resources. And we hope that with this model, it'll expand and we can see how that can benefit folks, so they're not just having to link in with Medicare or Medicaid to get these services. So thank you for letting me be here. I'm really excited to continue on this front.
And 3 quick points that I'd like to wrap up on is, 1, please, if you're advocating, please think through, and any Star Wars fans out there, Jedi, justice, equity, diversity, and inclusion. And I usually like to add language in there as well, so Jedi, I guess. But the cultural competency piece is so important. We've actually been finding that there was a study that was just released showing that Asian Americans are least likely to adopt technology. In our own programming, we started off very small, where we have received a contract to serve 25 Mandarin-speaking participants. There is so much need in Santa Clara County. We're getting 144 participants in one of our sessions. The second piece, too, is just to do a shameless plug for the OATS licensing program. We have now expanded our model where if you know of an older adult community center or organization like a health clinic that is struggling to provide digital inclusion or digital literacy programming, we actually have a licensing program where we provide all of our curriculum for free. And on top of that, we provide staff support from our own trainers to teach the local trusted entities out there in communities that may not have access to resources to be able to deliver our programming. And then the final piece, too, is I do feel like there are a lot of challenges ahead, but I'd like to think of it as an opportunity. I think we have an opportunity right now to really do this correctly if we can, and this is where I'd like to applaud CDA. I think the fact that they are really being thoughtful in rolling out dollars both through the ATT program and the CHAT program, the CHAT program and ATT program. I want to thank Tanya's thoughtfulness for rolling out these dollars in a very effective way. Just really quickly on that, the CHAT program is much more of a statewide approach, and the ATT program is much more of a local control county approach. And so I just wanted to thank everyone today, and I'll be staying here after if anyone has questions.
Please join me in thanking the panelists.